Okay, welcome everybody. I think we'll make a start and I'm sure other people will join in as we proceed. My name is Emma Orefuwa. I'm the Programs Director for Africa for the Global Action Fund for Fungal Infections. I'm delighted to be moderating this session today along with Dr. David Meya. And today's session will be about identifying advanced HIV disease with immediate CD4 testing in Africa. Those of you who all know GAFFI know that we work to tackle fungal infections worldwide. And one of our building blocks is enabling access to diagnostics for fungal disease in low and middle income countries. Today, we'll be hearing from some distinguished speakers from Uganda, Senegal, South Africa, and Ethiopia about CD4 testing. And namely, we'll be learning a bit more about the new innovation of the CD4 LFA test as well. So just a bit of housekeeping before we move on. We do have interpretation available today. So if you look at the bottom of your screen, you should see an icon with a globe that says interpretation. We have interpretation for French, Spanish, and Portuguese. So if you do need this function, just click on the globe and select the relevant language. You will also see at the bottom of the screen a Q&A box. So we encourage you to drop your questions in the Q&A box. We also have the chat feature, but please do use the Q&A box for the questions so that we can track those. I'll come to those in the Q&A session towards the end of the webinar. At registration, those of you who registered will have seen an option for CPD points. So we do have approval from the Royal College of Pathologists for CPD points for this session. So if you'd like that and you haven't indicated on the registration, please do drop us a note in the chat and my colleague Richard Penny will follow up on that with you. And just to let you know that this session is being recorded. I'm now going to hand over to my co-moderator, Dr. David Meya, to give a few words before we start. David?
Thank you, Emma. And I'd like to just again welcome everybody to this important webinar, revisiting the importance of CD4 testing, but in the context of advanced disease. And we'll be hearing several important talks relating to advanced HIV disease and why CD4 testing is still not yet out of the window, because we know that the definition that WHO has advanced is sort of focusing on patients with advanced HIV disease defined as people with a CD4 count less than 200. And I think one of the key things from this webinar is learning about the VISITECT, which is the VISITECT CD4 Advanced Disease, which is a unique instrument-free, rapid and disposable CD4 test that we know will be contributing significantly to the identification of those with advanced HIV disease who basically come to in healthcare settings. As one particular example is obviously cryptococcal disease, which continues to contribute to almost 15% of HIV-related mortality annually. And as part of the process for identifying who has cryptococcal disease, we know that the CD4, identifying those with advanced HIV disease is important. And that's, hopefully we will be able to leave this webinar having been reminded about the importance of CD4 testing in the management of advanced HIV disease. I'd like to introduce the first speaker at this point, and I will just give a second to do that. Dr. Moussa Sarr is well respected in Senegal and the region. He currently holds the position of principal investigator and head of business development and the cooperation group at Oerson, which is the Institut de Recherche en Santé de Surveillance Épidémiologique et Information in Dakar, Senegal. I needed to practice my French there. Prior to this, he spent over 20 years working as a senior and principal investigator for WestArt. He holds a medical degree and a master's of public health, as well as a postdoctoral fellowship. Moussa, please go ahead and share your slides and start your talk. Thank you.
All right. Thank you, David. All right, so we're good. So good morning, good afternoon, everybody, based on where you are. We'll be discussing the West Africa experience with VISITECT CD4 Advanced HIV Disease and Advanced HIV Disease algorithms. Okay. So first of all, I will give an overview of IRSF, the Institut de Recherche en Santé, de Surveillance Épidémiologique et de Formation, or Institute for Research in Health Epidemiological Surveillance and Training in English, which is a not-for-profit public institution with US 501c3 equivalency certification. The Institute brings together a multidisciplinary team of African and Pan-African faculty members and experts. It has a state-of-the-art modern laboratories with ISO 15189 plus accreditation through Public Health Canada. Several technical units, immunology, molecular biology, virology, bacteriology, through biobanking, data management, and IT with cross-cutting activities. This is a little overview also of Senegal, where we are located, the city, and then also some pictures of IRSF to give you a little idea of where we are and how the institute looks like. Advanced HIV disease, it is a persistent problem. 38% of patients still start antiretroviral treatment with advanced HIV disease. In Senegal, approximately 35% of HIV positive individuals initiate antiretroviral treatment with advanced HIV disease, defined by WHO CD4 count less than 200, or a clinical stage 3 or 4. Senegal has a concentrated epidemic with a low prevalence in the general population, approximately at 0.3%, but with high prevalence among key populations such as female sex workers, 5% prevalence, and men having sex with men are approximately 30% prevalence. To get back to the CD4 is still an issue and is still important. It is important to better understand and clearly define the role of CD4 testing as part of the HIV continuum of patient care. CD4 testing still also has a role to play in the staging of newly diagnosed and treatment experienced HIV positive patients, and in the context of preventing and diagnosing opportunistic infections. In many cases, the systems and capabilities to get viral load testing results and act promptly on it are still a challenge. And viral load testing also still remains costly and often not feasible also in many contexts. Where the need for a simplified, affordable, and reliable point of care testing for CD4. CD4 testing, for example, with instruments such as FACSCount and PIMA are no longer available in most countries. The VISITECT CD4 Advanced HIV Disease lateral flow assay can be a disposable point of care testing and providing a visual interpretation of results below and above CD200 CD4 cells per millimeter cube. This has also shown, previous studies have also shown a high sensitivity and specificity for the VISITECT CD4 Advanced HIV Disease. This is just a general kind of a view and a picture of the VISITECT test kits. So in Senegal, we are conducting a pilot implementation of the WHO Advanced HIV Disease Package of Care and related tools in the West African context. And so why West Africa? Because most studies conducted to date are in Southern and East Africa. Also in West Africa, we have different HIV-1 subtypes. We also have the presence of HIV-1, HIV-2 with possibilities also of dual HIV-1 and HIV-2 infections. Where the need to implement or at least test the implementation of the Advanced HIV Disease Package of Care. The package of care include the current recommended national treatment and prophylaxis guidelines. In addition to that, we're adding the TB LAM testing for diagnosing TB among people with symptoms and signs of TB. We also conduct cryptococcal antigen screening. We're gonna have, I'll be discussing a little bit later, algorithms based on the findings of those two screenings that we're adding to the national guidelines and treatments. This will be a two-phase study. Phase one, during this phase, we assess the performance, sensitivity, and specificity of the VISITECT CD4 Advanced HIV Disease product when compared to the BD FACS count flow cytometry testing. That phase of the study is completed. And then the phase two that is going to start in end of August or September will pilot the implementation of the package of care for those with advanced HIV disease as identified by the VISITECT CD4 Advanced Disease testing. Phase one, as I mentioned earlier, is currently finalized. It was conducted in Dakar with 237 patients in the FAN, Pekin, and the Institut d'Hygiène Sociale hospitals and the health centers of Keur Massar and Rufisque, which are all in Dakar or the outskirts of Dakar. Overall, as I mentioned earlier, we have 237 patients enrolled with a mean age of 41 years old. And approximately half of those patients, 49%, were female. The second phase is expecting to enroll 1,500 patients at the health centers of Ziguinchor and Bignona, which are all located in the southern part of Senegal. The criteria are a high burden of HIV-1 and HIV-2 and advanced HIV disease. Having access to laboratory CD4 testing on site, the implementing partners' capabilities, and their capabilities also to provide appropriate clinic care for treatment for cryptococcal meningitis and TB treatment. The inclusion criteria for both phases, it's a completion of a written informed consent form. Being 15 years old and above. And then for phase two, in addition to that, they'll have to have an advanced HIV disease diagnosis based on CD4 less than 200 or a WHO clinical stage of 3 or 4. We also don't want them to relocate while during the follow-up period. So this is the first findings that for the study with the phase two analysis. We compared the performance of VISITECT CD4 Advanced HIV Disease to the BD FACS count. And as you can see, we have also this high sensitivity for the VISITECT with a sensitivity at 93%. Confidence of interval going from 76 to 99, and also a high specificity at 91%, with a confidence of interval going from 87 to 95. This is to give you an idea of the algorithms that we will be using during the phase two. So for patients who have a CD4 less than 200 and a WHO clinical stage of 3 or 4, in addition to the treatment and prophylaxis based on as recommended by the national guidelines. We'll also be doing the TB-LAM testing in the urine, and then also the cryptococcal antigen testing on venous blood. So I'll discuss in the following algorithms what's going to happen based on those two screening that we're adding to the routine management of patients in country. For the crypto antigen screening algorithm, for those who are negative and also have a TB-LAM negative and no presumptive TB treatment, they will be receiving treatment and prophylaxis based on the national guidelines. For those who are positive, we're going to assess the symptoms of cryptococcal meningitis. If they are asymptomatic, we'll inform the patient about the signs and follow them up closely for signs of cryptococcal meningitis. And then we'll also provide them with fluconazole 800 milligram daily for 10 weeks, followed by fluconazole 200 milligram daily for a minimum of a year. For those who are crypto positive and symptomatic, we're going to start fluconazole 1,200 milligram daily and refer them for lumbar puncture. And so if the lumbar puncture is negative, they will receive the same treatment as those who are asymptomatic. And for those who are positive, we'll put them on amphotericin B plus 5-FC for 1 week, then fluco 1,200 daily for a week, and then fluconazole 800 milligram daily for 8 weeks, followed by fluconazole 200 milligram daily for at least 10 months. To mention also that we're going to delay antiretroviral treatment initially for 2 weeks for those patients. TB-LAM, if the algorithm, if the TB-LAM is negative and the crypto antigen testing is also negative, we're gonna they will be receiving treatment and prophylaxis based on national guidelines, including the initiation of antiretroviral treatment. If they are positive, if they are negative, and you're going to do a TB screening. Also, if the TB screening is positive, we're going to do the gene expert sputum. If the expert is negative, we're going to rule out TB. And then if the expert is positive, we're going to start also initiate TB treatment. The same thing then if the TB-LAM is positive, we're going to also initiate TB treatment. In conclusion, the VISITECT CD4 Advanced HIV Disease displayed high sensitivity and specificity when compared to the BD fax count flow cytometry in Senegal and in the West African context. This is taking into account that we have a specific subtype of HIV-1, and then there's possibilities also for HIV-1 and HIV-2 co-infections. This offers a promising alternative for a decentralized CD4 screening and testing in resource limiting setting, as it can provide guidance and a prompt management of patients with advanced HIV disease in our context. What to do next? We are currently working with the Ministry of Health. They are part of our protocol team. The Ministry of Health is very interested in the possible implementation of the point-of-care CD4 testing in country. We're planning a national dissemination meeting with the Ministry of Health, but also with key in-country stakeholders. The possibility to include major study recommendations into the next national strategic plan is considered for sustainability purposes. So we want to thank our partners, the CDC Foundation, Omega Diagnostics. Special thanks also to all study participants and site staff, and the Senegalese government, the National Council Against AIDS, which were under the Prime Minister's Office, and the Division of the Control of HIV/AIDS and STIs under the Ministry of Health. Voilà, thank you and merci.
Okay, thank you very much, Moussa. So next speaker, Mr. Tafese Tufa, is an assistant professor of clinical microbiology at RC University College of Health Science in Asella, Ethiopia. He's also the coordinator of the Harsh Institute of Tropical Medicine in Ethiopia, which was established through the collaboration between Heinrich Heine University in Düsseldorf and RC University in 2013. Tessa, please go ahead with your talk.
Okay, thank you, Dr. David. It is my great pleasure to get this chance to talk about CD4 testing experience in Ethiopia. So my talk will be about the advantage of point-of-care CD4 testing and comparing with central laboratory testing. I also would like to thank GAFFI to give me this chance. Before I start my talk, I would like to say about Helsinki Institute of Tropical Medicine shortly. It was established 2013 through collaboration with RC University and Heinrich Heine University of Düsseldorf, Germany. The founder of this institute was Professor Osinga, and now the current director of this institute is Professor Lude. The contact person is Dr. Fed, and I and my colleagues, Dr. Yanek, we are now coordinating from Ethiopia. As you see, it is found 175 kilometers away from capital city Addis Ababa to the southeast. So if you're interested to collaborate with us, everybody welcome, and contact me or Dr. Fed. Having said this, let's pass to my talk. This is my talk outline. As introduction, we all know CD4 testing is remaining an important part of HIV treatment and the care due to several reasons, like to assess the disease progression, to make decision about ART regimen changes if it's needed based on immunological response, treating HIV infected individuals with opportunity infection. There are essential criteria to define point of care tests, POC, just focus to patient impact. For example, it has to be the result the same day, the same site, and also the result should be available within 30 minutes. While we use also, it has to be easy and should be applicable by non-laboratory personnel, no precise samples, and the sample collection also should be easy and then with someone not trained well. And the result interpretation should be easy, because after the running this point of care test, everybody can interpret the result. Regarding to the cost should be equivalent or less with conventional testing. Equipment and the consumables also should be cheap. How to deploy this POC? It is just not need electricity and the refrigerators. If it's needed, also just the battery power or alternative power should be as alternative. The size should be small and easily just portable, and no need expert to install it. Long shelf life, minimum 6 months. And how to waste also, just dispose the waste also should be safe and easy. When I came to the quality control, just the internal quality control should pass first before we use these POC tests, and it should be also compatible with external quality assurance we have. Having said about POC introduction, when I came to Ethiopian Health Service Delivery Arrangement, there are primary, secondary, and tertiary level. At primary level, just we do have health posts. This health post gives service for maximum 5,000 people, and the health centers up to 25,000. primary hospitals up to 100,000 people. For secondary level healthcare service, there is a general hospital which can serve up to 1.5 million people, and the tertiary level one is teaching hospital or university hospitals, which can serve up to 5 million. My hospital, as a teaching hospital, also one of that. According to I got a report from Ministry of Health. Currently, we do have around 338 hospitals and some under construction. We also have around 4,000 health centers and 17,550 health posts. Imagine it is difficult to provide CD4 testing or RT service at this all. That's why we need point of care CD4 testing. There is a capacity of health facility for diagnosis and treatment of HIV/AIDS in Ethiopia. There was a study just focused on 8 indicators. According to these indicators, like the 8 points, HIV counseling and testing, all component of PMCT, baseline CD4 testing, and CD4 or paraload for monitoring ART using guidelines, availability of the drug, screening of TB. So considering these, according to that finding, just, you know, this map is Ethiopian map, just based on administrative purpose. There are 9 regions. From these regions, you see, those the red color is those do have capacity and the readiness score more than 50%. And the rest is less than 50%. So you can see the red color just in the central Oromia region and also in the north part, Tigray region. So just their readiness is good. I mean, more than 50%. And also some part of Somalia. I got also reports just from recently from Ministry of Health. The machine we do have for CD4 testing, some of them POC, some just central, which we used it before. So here we have PIMA machines at 133 health facility, and we also have BD fax Bridgestone 231 and the fax caliber machine 19 at regional or national center. So according to the report I got, only 26% of ART clinics could provide CD4 testing service right now. Just the rest are just transferring samples to the nearest health facilities. So the sample transfer linkage seems, as you see from the picture, just 4 health centers transfer the samples to one health facility or health centers. There was a study done about the capacity of health facility for diagnosis and treatment of HIV/AIDS in Ethiopia. According to this finding, it was published recently, less than 5% of private facility providing ART service, and 1/3 of health centers, and 87% of hospitals, especially those teaching hospitals, fully provide ART service, but some still primary hospitals not providing the service. According to this finding, the recommendation was improving the capacity to reach the rural area, also to expand to the private health facility. So in general, the service of HIV or ART here is significant based on, there is a significant difference based on the geography or location. When I came to the difficulties of central laboratory CD4 testing, you all know there is a patient burden, specimen referral, and staff recruitment, cold chain, service and maintenance. Due to this, it is very difficult to just reach across the country of all health facilities. That's why the point of care CD4 testing is very essential. To say a few things about this benefit of POC, to expand time access to CD4 testing, increase time initiation of ART. It can simplify ART at primary care level and then easily decentralize it. It can also use to establish a baseline for patient beginning treatment, reduce patient loss to follow up, reduce cost is easy to use. These all are the benefit we will get from POC CD4 testing. Sorry. Especially this POC CD4 testing for advanced HIV disease, really it helped to accelerate clinical disease management and reduce burden of healthcare workers. It also improves patient outcome, as we have seen from the previous presentation, because those advanced HIV patients got support to screen OI or opportunistic infection. To initiate prophylaxis, we should know the CD4 level of our patient, and also to select a group to screen TB LAM, like also crack lateral fluorescence. There is also some drawbacks about POC CD4 testing. It may need some massive training for expansion the service. Managing the supply chain also will be challenging. Implementation of external quality assurance programs due to the large number of testing sites, as well as difficulty of monitoring and the evaluation of the data from the decentralized sites. And if we want also to repeat the test, no left samples, because we only use small sample volume or capillary samples. Thank you very much for listening to me. This is all what I have.
Thank you very much, Tafese. So I'm now going to move on to our next speaker, who is also our co-moderator, who will be Dr. David Meya. So just a brief introduction to David. David is an associate professor in the School of Medicine at the College of Health Sciences at Makerere University, and holds an appointment as an adjunct associate professor at the University of Minnesota. He's been involved in clinical research of central nervous system infections and complications, with a focus on HIV immune reconstitution inflammatory syndrome, or IRIS. David also chairs the Advanced HIV Disease Technical Working Group at the Ministry of Health, and continues to be involved in advocacy to improve clinical care and outcomes in HIV patient populations in LMIC settings. So with much, I'll hand over to you now, David.
Thank you, Emma, for your introduction. And for the talk this afternoon, I just wanted to spend a few minutes really highlighting the fact that there are, even among people who start ART, those who will have variable changes in their CD4 counts after they start ART initiation, and just to offer some thoughts on when one would retest and what to do with those particular individuals. I think it's important that we go back to the early events in HIV infection, where we have the HIV variants crossing the whatever mucosal barrier it is. That takes place over just a couple of hours, and then there's infection, of course, of the CD4 T cells, which then become activated. And over a couple of days and weeks, we know that some of those cells have this established lymphoid tissue viral reservoir, and there's ongoing immune activation, and over many years you sort of have this sustained HIV production because of those viral reservoirs. And we haven't stopped talking about CD4 T cells despite, you know, the advances in HIV care. And I think it's important to remember that there's considerable variability in the magnitude and the rate of CD4 T cell count recovery, as I'd mentioned. We know that some patients fail to attain CD4 counts that exceed 200 cells. And therefore, they sort of remain within the WHO advanced HIV definition, as the previous speakers had highlighted, despite having suppression of their viral replication. And there have been several studies that have demonstrated that the frequency of this, what one would call suboptimal immunological response to ART, varies between 7 to 20%, and typically depends on the duration of ART. We also know that there's conflicting data on the correlation of suboptimal CD4 response with clinical morbidity, and the focus here is obviously the susceptibility of these individuals to opportunistic infections, as I will highlight in the next couple of slides. We think about the kinetics of CD4 T cells in HIV infection, and that's why we're able to come up with definitions of suboptimal CD4 responses. And so in this study that was done in Uganda, one example of the definition was really for those who had a CD4 count that remained less than 50 after 6 months of ART, or less than 100 after 12 months of ART, or less than 200 after 2 years of ART, were defined as having suboptimal CD4 responses. But we also know that one could essentially say that the failure to achieve a CD4 cell count above a threshold of 200 at 6, 12, and 24 months could essentially be, in a nutshell, that could be the definition of suboptimal CD4 responses. And at the Infectious Diseases Institute in Kampala, Uganda, among a cohort of about 560 HIV-infected individuals, approximately 2 years after they had been on ART, you know, they showed a median change of about 54 cells among those with suboptimal CD4 responses. And in terms of the specific criteria, those with CD4 less than 50 were about 21%. Those with CD4 having failed to achieve a CD4 less than 100 were 45%, and 54% at the 6, 12, and 24-month time points. I highlight two important studies that I came across, again, one from Uganda, that was looking at the frequency and impact of suboptimal immune responses within a couple of countries within East Africa. And when they looked at the rates of CD4 change, they found that up to 40% remained with a CD4 below 350 after 5 years of ART, which is a fairly significant chunk of individuals. And in this study that was reported by Stawski and others in 1999, again, they showed that individuals who had, the greater the CD4 change or increase, the greater the mean change in the log, HIV viral load as well. And if you look at those who sort of had a smaller mean change of about 50, again, the degree of change in terms of the log, viral load, was not as significantly high as those who had a greater CD4 change. So just coming back to this study that I mentioned at the Infectious Diseases Institute, just a very quick profile of those individuals. After 4 years of ART, 254 had sustained viral suppression up to 4 years. And among those, they picked 211 who were eligible for this study. And this really just highlighted the median CD4 increase among those who had been split in suboptimal responders, with a median CD4 increase of about 129, and those who were thought to have optimal CD4 response had a median CD4 increase of about 282, and the super responders in the highest quartile were found to have a median increase of about 500 CD4 cells over that period of time. We also know that there is an impact on the CD8 T cell activation, and as this study went on to demonstrate, individuals who had suboptimal responses similarly had high activation, immune activation of their CD8 T cells. And the question is whether this is a compensatory mechanism since their CD4 T cells are not sufficiently increasing, and whether this impacts on responses to opportunistic infections with the CD8 T cells sort of becoming much more activated. And this slide really also just highlights the fact that there were other changes in terms of cell phenotypes, and specifically the natural killer cells in the population of individuals who had suboptimal immune response. And they found that those individuals had an increase in these pro-inflammatory natural killer cell phenotypes. And again, it's unclear how this contributes, obviously, to immunosenescence that HIV itself can cause, especially in individuals who are with suboptimal CD4 responses. And going back to the question of ART and CD4 response, there are obviously implications for clinical care. So if you have a huge population of individuals who are started on ART, especially when they have advanced HIV disease, and you begin to have a greater proportion of them with these suboptimal CD4 responses, what are the implications on clinical care? What are the implications on ensuring that they remain HIV free, rather they remain free of opportunistic infections? In this study, again, that was published in Uganda, they didn't really find any difference in terms of clinical events among suboptimal responders and those who had optimal CD4 responses, as shown in this Kaplan-Meier curve. Whereas in this study in South Africa, the overall mortality was related to the proportions of person time accrued within low CD4 cell strata, which really just means that individuals who had, the lowest increases, the lowest current CD4 cell count between 0 to 49, that were grouped in 50s, that those who had the lowest CD4s also had the highest mortality rate. And this was mostly attributed to TB infections in this population of people with poor immune CD4 responses. And I think one big question that comes up is, does immunological failure still matter? So we know the WHO definition of immunological failure, and I suppose this was published in the last, either the last 2 or 3 iterations of the HIV guidelines. It was clear that a CD4 count fall to the baseline or below baseline, persistent CD4 levels below 100, and among children below 5, persistent CD4 level below 200 was sort of the classical definition of immunological failure. However, I think what has been observed is that this definition has low sensitivity for identifying those who have virological failure. And that's one of the major reasons why we currently use viral load monitoring as the standard of care. I believe among the individuals with suboptimal responses, we it's still important to maintain cotrimoxazole, and I think monitoring viral load as recommended is still important. The beauty of platforms that can evaluate CD4 thresholds of those with advanced HIV disease, especially now that we have the VISITECT, I think will increasingly become obvious that it's then sort of easy to institute monitoring for individuals who continue to have slow CD4 responses. And so the question is, should we be monitoring these individuals doing a CD4 using the VISITECT twice a year? And the bottom line is really identifying and treating opportunistic infections. And so as has been highlighted by the previous presenters, the urine LAM and serum cryptococcal antigen become the natural steps to follow once individuals have been shown to have a CD4 threshold of less than 200. And so in treatment programs, just to summarize, it's important to remember that there will be individuals who are whose responses, CD4 responses, will be variable. And it's important to keep an eye out for those who especially have suboptimal CD4 responses. Thank you very much.
Thank you very much, David. I'm now going to move on to our final speaker for today, who is Mr. Joseph Oerson. Joseph is the Director of Sales for Africa at Omega Diagnostics. He holds a BSc degree in Chemistry and Physics from the University of Western Cape and a postgraduate diploma in Business Administration from the University of Wales. David has held several positions in the diagnostics field with vast experience across the continent and has worked with many stakeholders, including ministries of health, NGOs, faith-based organizations and funders. And Joseph is now going to talk about the VISITECT CD4 tests. Over to you, Joseph.
Thank you very much indeed. Greetings to you all. It is my pleasure to be here. And we are grateful for the opportunity that we have to be able to speak about this very important subject, having access to same-day CD4 testing. So thank you very much indeed. For today, the next few minutes, I'll be talking to you just very briefly, give you a brief company overview, just reflect very briefly on the WHO guidelines, just a quick product overview, and then just talk to you very shortly about the regulatory status of the product, the scientific evidence, and then more importantly, what support we can offer to you who are interested to implement the product in your setting. So firstly, let me talk very quickly about Omega Diagnostics. Omega Diagnostics is a publicly traded company. We're listed on the AIM section of the London Stock Exchange. We're headquartered in Scotland, in Elva, Scotland, in the UK. And the product is manufactured at a GMP site. We have ISO 13485, so you are assured of a quality product when you receive that in hand. The VISITECT CD4 Advanced Disease is a product that was initially conceptualized and developed by the Burnett Institute, and my colleague Iman Alexic, the Global Product Manager at Omega Diagnostics, previously worked at the Burnett Institute. She's on the call with us today. So since the product has been developed, there's been a successful transfer of technology, and since then the product has been optimized, verified, and validated. And today we have a commercially available product that can assist with the identification of advanced HIV disease. Just concluding the remarks on the company overview, Omega Diagnostics has sufficient capacity to supply current and future demand. We have a very strong leadership team. We are sound financially, and despite the challenges that we faced during the pandemic, we continue to operate well, and we are able to supply the product when it's required. So much investment has been made over the years. And that has resulted in us delivering the first and only CD4 rapid semi-quantitative test to answer some of the questions that was raised in the chat line. So it's a semi-quantitative test that is available. More importantly, also, we just want to talk about advanced disease. We know that advanced disease is defined by WHO as adults and children older than 5 years that has CD4 cell count of less 200 or less, or also clinically stage 3 and stage 4. And these patients require special counseling. Just talking very briefly about what is the hindrance or the barriers to advanced HIV disease and how it can be addressed. We know that there's been a focus on viral load, and that has resulted in CD4 sort of disappearing into the background. It's also caused some of the infrastructure of CD4, if you like, being demised, machines not being serviced, reagents not being available, and that has caused a barrier for CD4 right now. We know that in little lower and middle income countries, many people live far away from health facilities, and those in the rural communities have then their blood taken, sent to a central lab, and we know that they can wait days for a CD4 result. This then means that the patient has to come twice, so once for the test and then for the result. And we know that there's not sufficient infrastructure in place to move these samples around to the various facilities. So we have a solution for this, for the challenges that we have. So we have VISITECT CD4 Advanced Disease, and right in front of you, you see the product. It comes in a carton of a kit of 25. It has everything that you need to perform a semi-quantitative rapid CD4 test. You have the alcohol swab, you have a collection device, retractable Lancet, a buffer to perform 25 tests, and then of course the cassette to do the test. The test is a very simple test. It can be done with a capillary sample and also venous. You require 30 microliters of blood that is dispensed into well A. You then wait for 3 minutes. You add 1 drop of buffer to the same well. You then wait 17 minutes, and then you add 3 drops of buffer to well B. You then wait 20 minutes for the result, after which you have 5 minutes to interpret the result. It's a very simple test, yet we have complex chemistry underneath in the cassette. The results are interpreted as follows. The first check always is we have to make sure that we have a control line and we have a reference line in place. Once that is there, then we know that we have a valid result. We then compare the test line with the reference line. So on the left-hand side of the screen, if the test line is less intense than the reference line, then the result is read as a below reference. Also, if the line is absent, that is also read as a below reference. On the right-hand side, the test line is more intense than the reference line. Then you read the result as a below reference. Now, the 200 is important because we know that that's how WHO defines advanced HIV disease, as those having a CD4 count of less than 200. So this gives you the opportunity then, when the patient is with you, once they test positive for HIV, you can then do a semi-quantitative CD4 test, and then the clinician is then empowered to make an informed decision right there and then. So these are then the benefits of having VISITECT CD4 Advanced Disease. You are empowered to make a decision, so you don't have to take the blood, send it to the lab, and wait for the results to come back after days. You can do a result immediately, a test immediately, have the result available. It empowers the clinician, and you can then make an informed decision to screen for other opportunistic infections if the result is below 200, or put the patient on treatment if that's not the case. So that means that the patient, there's a reduced patient loss to follow up, because you see the patient, you give them the result, and you can treat them accordingly. As you have seen from the previous slides, there is no equipment required. Whatever you need to do the CD4 test is within the box. So there are no additional equipment that is required. So no sample transportation. When you have the patient in front of you, you do the test right there and then, and you can have a result. So this you can test anywhere, anytime, and then really it improves patient outcomes because you now have a CD4 result available immediately, and you can then make an informed decision. Performance evaluation or the performance of the test, the package insert claims sensitivity of 89 and 92 specificity for capillary, and also for the venous blood sensitivity of 86 and 92. That's in the pack insert. It's roughly the same for both capillary and venous. Sensitivity, very quickly, is the ability of the test to measure accurately a result that is below 200, and specificity, the ability of the test to accurately measure a result above 200. We also have the MSF data that was published. It's a multi-country study, and it's very much in line with the package insert claims. Just concluding, in a few final slides. The product has been CE marked since 2019. We did get the ERPD in September of 2019, and we were pre-qualified in 2020. Also, very important aspect is we have funder support, in particular under the EMAV agreement, the Early Market Access Vehicle, an agreement that is signed between the funder, Unit Aid, the Secretariat, CHI, and then the manufacturer, Omega Diagnostics. And in this agreement, it allows for multiple countries, up to 130 low and middle income countries, to access the product at a ceiling price of $3.98, which is an ex-works price. So obviously it's going to land at different cost in various countries. There's also a number of studies, some of which you have heard today, in West Africa, Senegal, where the product has been evaluated independently, and the results we see as being consistent with the pack insert claims. So finally, VISITECT CD4 Advanced Disease remains the first and only semi-qualitative rapid test available, so it helps the clinicians to make an informed decision. We do have funding support. The product is specifically called out in COP21. The VISITECT CD4 Advanced Disease is a semi-qualitative test that's available, so there's no need for instruments. You can do a rapid test for CD4, semi-qualitative rapid test. The users are encouraged under the COP21 guidance to use the product. And of course, we've already spoken about the Early Market Access Vehicle. We have seen the rollouts in a number of countries, in particular in Uganda, in Nigeria, Zimbabwe, Malawi, Mozambique, and some other countries. So the EMAV agreement allows for implementing partners to procure up to 50,000 tests per country, and there's 130 countries that have access to this agreement. Finally, there's good support from Omega Diagnostics. We have conducted many trainings both in person and through Zoom, and now with our Global Learning Center, so we can offer adequate support for implementation and rollout for this product. We've recently conducted our biggest training session in Uganda, where we've trained 47 trainers to roll out the product in country. So there's sufficient support both in person and online for the correct use and application of the product. Finally, VISITECT CD4 Advanced Disease is the gateway to the AHD package of care. It gives you a semi-quantitative result. It can tell you whether you have a CD4 count of below or above 200. It is a pre-qualified product. We have seen very good uptake under the EMAV agreement. We have donor support, and there is significant evidence to support the product in various countries. So the Omega team is here. We are able to support you. We do have our contact details available, so please feel free to reach out and contact us if you require any support. Thank you for listening. Over to you. Thank you.
Thank you so much, Joseph, for that wonderful overview of the VISITECT CD4 assay. Before we move into the Q&A session, and I think it's important that we give time to answer some of the questions that have been put through, we're just going to launch a quick poll because we want to gauge your feedback on the test. So I'm going to ask my colleagues to launch the poll quickly. So you should be able to see on your screen a question asking, do you find the same-day LFA CD4 test useful in your setting? I'm going to give you a few minutes, or actually seconds, just to answer that. Okay, 10 more seconds. We've got half of the people have voted, so please do get in with your vote in the next few seconds.
Can I answer my question?
We'll come to the Q&A session in a second, Professor. We're just going to conduct the poll. Okay, so I'll close the poll now and I'll share the results. So the overwhelming majority of respondents have stated that the CD4 test would be useful in their settings. There's 86% said yes, 10% said no, and 5% said they don't know. So that's very interesting. I think there's going to be a lot of interest, and I'm sure the Omega team will have lots of people contacting them for further information about how to access this test and initiate it in their countries. Thank you, everybody, for participating in that. So we have a few questions, and I'm just going to go to the Q&A box to pull those out. So the first question is from Nigel Tungwarara, and this is directed to Tafese. How does the CD4 testing gaps in Ethiopia impact on the linkages of patients to care and treatment? Did you collect any data on leakages as far as the treatment cascade is concerned in the facilities with no CD4 testing? So Tafese, please feel free to answer that question.
Okay, thank you for a really excellent question. We didn't collect any data about the gaps or the problems, but practically we have seen the gaps because sometimes the cartilage stock out, and also still the sample transfer is ongoing. So during sample transporting, there is delays and other problems. So to be frank, we didn't collect any data, but there is a problem.
Thank you, Tafese. We have another question from Christine Mandenge. So Christine has asked, how do we get these tests into Cameroon? And I know, Joseph, you touched on Unitaid and Chai as a vehicle, but maybe you want to expand on that.
Yes, thank you very much indeed. So firstly, in Cameroon, we do have a distributor in country based in Douala, Lab Solutions. So I'd be happy to take the contact and forward that onto you. But the test is available. We are currently in the process of doing an evaluation through CDC in Cameroon. So the test will be available in country as well. So I'm happy to respond or provide the contact details as well.
Thank you, Joseph. And Christine is our ambassador for GAFFI in Cameroon. So Christine, happy to link you up with Joseph to have further dialogue on that if required. I do not see any other questions, but I just wanted to give 1 or 2 minutes for any final burning questions from anybody. I'll just check the chat as well. No further questions? Elvis Temfak. So Elvis, I'm going to see if we can let you ask your question live. So I'm going to allow you to talk. Okay, Elvis, please fire away.
Okay, thank you very much, Emma, for giving me the floor. I have a question. It's a very general question, and I want to address this to Professor Meya. about consideration of other fungal infections, most especially as we see from the experience in South America that about 50% of the patients who are suspected for TB have other opportunistic infections like histoplasmosis. And given that his team is doing a lot of work on advanced HIV, has there been any consideration for some cross-cutting studies in Africa to see the burden of histoplasmosis among advanced HIV patients? Thank you.
Thank you, Elvis. I think that's an important question, an important consideration to think about. We know that the WHO advanced HIV disease guidelines are obviously may not necessarily be cross-cutting for each region. And as you rightly mentioned, I think histoplasmosis in South America seems to be occurring more frequently than, for example, in East and Southern Africa. There are studies that I believe there was just one study that we did, and it was really an estimate of the numbers of individuals with histoplasmosis. Part of the reason, of course, has been that the diagnostics for histoplasmosis have been a challenge in most places, where histoplasmosis might not necessarily be one of the initial classical presentations of disease in patients with advanced HIV disease. And so we, the figures are really just estimates, but it appeared that the frequency, especially in East Africa, I think seemed to be fairly low. Having said that, there are plans to evaluate rapid diagnostic tests, and I think there's a histoplasmosis LFA that has been that has been put together, I think, by a company out of Europe. And one of the things we're considering for the future, and the plans are in place to sort of just do some studies among those with advanced HIV disease, looking at the possible prevalence using this LFA. And agreeably, there'll be patients who might show up, either in surgical units, or who might not necessarily show up with classical histoplasmosis that might be missed. But I think this will be a first step in evaluating the prevalence, or determining the prevalence of histoplasmosis in East Africa, in Uganda, among those with advanced HIV disease. Thank you. I hope that answers your question.
Thank you very much.
Thank you, David, and thank you, Elvis, for the question. I think that's all the questions that we have. I see my colleague Eman is answering a question. Oh, there's one more question from Elizabeth, which I'll pose to everybody. Have there been any issues with healthcare providers having difficulties with interpretation, i.e. the subjectivity of intensity of the line in the assay? Would anybody, any of our panelists, Joseph or Moussa, like to answer that?
So if I can go first, Moussa, if you don't mind. So obviously it depends on the person reading the test. But I think with training, you train your eye. So you compare the test result versus the reference line. And you obviously need sufficient lighting. But we have some good training materials in the form of quizzes that help train the eye to read the result accurately.
Great. Thank you, Joseph. Thank you, everybody. I think we'll bring this session to a close, but if anybody has any other questions, please feel free to contact us. I'll ask my colleague Richard to put our email in the chat so that we can connect people if necessary. I'd like to thank all our speakers today. I'm sure you'll agree it's been a very informative session. We had a great opening by Moussa talking about the use of VISITECT within Senegal. And it's great to see the application of the test in a sort of real life setting. Tafese talked about the advantages of point of care testing and some of the challenges. And I think as the Senegal study rolls out, we'll be able to see how some of those challenges are being mitigated in that context. David gave a very good overview of immune recovery after ART and the implications for clinical care. And Joseph talked extensively about the CD4 tests. So I'm sure you'll agree that was a very comprehensive set of presentations. So I'll wrap up now, just to thank everybody for attending. As a reminder, those of you that have asked for CPD points will follow up and we'll get those certificates to you. We'll also share the slides and all the presentations with you shortly. And within GAFFI, we're keen to hold more of these webinars that suit the needs of our partners and people that are interested in fungal diseases. So if there are any specific topic areas that you'd like us to tackle, please feel free to contact us and we'll do our best to address that. So without further ado, I'd say thank you again. Thanks everybody. And we look forward to connecting with you soon. Have a good rest of the day. Bye-bye.